Chris, turning to you and thinking about your personal approach to how you, I suppose the timing and the choice of therapy for a patient with metastatic castration-resistant prostate cancer, chemo, androgen target agents or bone targeted therapy. What's your sort of approach to deciding on the timing and which choice of drug in an individual patient? What type of things do you consider?
Yeah, it's obviously a big question.
Yeah.
I mean, to simplify the question, should we take men who are managed with ADT alone up front?
Yeah.
So they've not seen ABI, they've not seen
yes,
dosing.
exactly. Yeah, yeah.
And so then we're left with a choice between the AR-targeted agents, the chemotherapy agents, and radium. And I think it's fair to say this is an evidence-free zone, so we can do what we think is best in terms of clinical judgment. So in that scenario, I typically use the AR-targeted agent first and the chemotherapy second, on the grounds that it's less toxic and leave the more toxic till later.
Yeah.
And I understand there are counter-arguments.
Yeah, we'll hear them in a moment, I'm sure.
And then if we're going to use radium-223, so if the patient has bone disease and does not have visceral disease, then my preference is to use that with the AR-targeted agent.
Yeah.
Not to delay it until they do get visceral disease, because that means they're never going to get radium.
Yeah.
And that seems to me the worst mistake you could make. Yeah. So although there isn't evidence to support that, that would be my preference.
That's your personal preference. What about you, Johann, in that situation?
No, I would agree with Chris. I would fully agree with what he said, actually.
Yeah. Bertrand?
I agree also with what we see, Johann already mentioned, but what we can say in terms of sequence is not more what we can do, but what we probably shouldn't do anymore. And something I see a lot, and I don't think there is overall, is patient 65 years old progressing on ENZA with a quite rapid progression, who actually are denied like chemotherapy and receive another shot of ABI if they had ENZA for 3-6 months. So I think at least that for the first 2 or 3 lines, we should at least exhaust the drug with proven benefit, meaning ABI or ENZA, docetaxel. And then maybe you have nothing, and then find a place for radium on top of that. But and it's like, I don't know, maybe you want, but like re-challenging docetaxel when they have received docetaxel. Yeah, it works. But if you have, and the patient can receive cabazitaxel, I mean, shouldn't still we do that? I'm not sure.
Can I just bring up the ARV7 story?
Please.
Because I was in a debate this morning and there was audience voting, and the majority of the audience would use or would want to use ARV7 status to decide this question, whether to use chemotherapy or AR-targeted therapy. And that was in spite of the fact that the panel at the front were unanimous that they would not advocate that. The panel were unanimous that there isn't enough evidence to support using ARV7 to make this decision.
I think people want to believe that it works, don't they?
I want to support the panel fully. I don't think ARV7 testing should be routine. In fact, there's very strong evidence that actually many cancers, up to 30%, with ARV7 positive disease respond very well to abiraterone and enzalutamide. So I think that actually is a poor interpretation of the data. And in fact, what I can tell you is that we do a lot of ARV7 testing on tumor biopsies with CRPC. Not many do this. And if you look at a biopsy for ARV7, you get islands that are AR wild type, full length AR, no V7, and islands with V7. So when you test V7 positive, you're not, most of the cancer is still AR wild type with some V7. And actually it really worries me, we have evidence that actually V7 positivity implies lots of CTCs. That's what it tells you. If you're V7 positive in blood, what it means is you have lots of circulating tumor cells. We published years ago that lots of circulating tumor cells is a bad prognosis. The reason that AR-V7 positive is highly prognostic is because you have lots of CTCs. We have no evidence for that. We've got a paper which is just submitting. So it worries me that those data have been hugely misinterpreted.
What worried me this morning at the debate is there was voting before and after the debate, and in spite of the fact that those arguments were put forward extremely clearly, the results of the votes were precisely the same. So people were still just as enthusiastic about ARV7 testing after the debate as they were before.
That is misplaced, I think.
Yeah, on top of that, I mean, this is a discussion that was generated in late use of ABI-ENZA. And actually we've got a good example, which is the Galeteron trial that was run in the enzalutamide prevailed scenario, where you use this in early CRPC asymptomatic patient. First of all, you're going to test a lot of patients, use a lot of resource to pick up a few patients, which anyway have a very, very poor prognostic. So the test which you believe is predictive actually is prognostic in a very small subgroup of patients and then useless. And actually, you probably would have the same benefit by giving 1-2 months of ENSA and monitoring and being once again more attentive at the PSA and the radiological response. That to do an expensive test, that, yeah, there's a company who do it, but it's one sequencing, so I would fully support not to do it, and we never do it.
And can I say, because my lab run this test in my lab, so I know this test intimately with great detail, this test does not have a good dynamic range. So actually what I mean by that is that very rapidly in these patients you come to a level of ARV7 that actually is very noisy. And all assays have this, but with this mRNA blood assay, it's a particularly big problem. What I mean by that is if you do the assay 3 times, the same blood test 3 times, you get different results every time. So I have great concerns about the use of this assay. And we now have data that some publishers are submitting in the paper that actually in many patients who truly have ARV7 in their tumor, in their tissue, in their biopsy, you don't find positivity in the blood. And they have high burden disease, lots of CDCs. So actually I don't think this is a good assay, and I'm really concerned that actually it's been, the community is being misled. That's my concern.